Hello, everyone, and welcome. Thank you so much for joining us for today's call. This is the ESRD Learning and Action Network series, focusing today on the home modality. This is the quality improvement activity for the June 12th, 2018 date. My name is O'Neil Double with the ESRD NCC. We have a lot planned for today's discussion. Of course, if you've joined one of these events before, you know that this was designed to be a very interactive call where you'll see polling as well as have the ability to communicate with us via chat. I just wanted to provide some housekeeping items, some reminders at the start of today's discussion. On screen, you can see the reminder that we are streaming audio for today's call, meaning you do not necessarily need to have a phone line to hear us. You can hear us through your computer speakers or if you have headphones, but know that we have a limited number of telephone lines available if you do not have speakers or headphones, so you can follow along with today's call. Also, if you are streaming and you currently hear an echo, echoes are caused due to multiple connections to the same event on one computer. So please double check to make sure that you close out all but one tab, so that will eliminate the echo that you might be hearing. Now, since you can hear from us, but we can't hear from you, we do encourage that you get involved, and you can ask us questions as we go on with today's session, as well as communicate with us by using the chat feature that's located on the left-hand side of your screen, where you'll be able to, once again, send in questions or comments. We do have multiple presenters on for today, so I will ask if you could please just indicate maybe the first name of the person who the question might be for, so that will help us with better asking or to ask that individual for you on your behalf. Here you can see on screen just a reminder of what I mentioned a little bit ago regarding a Learning and Action Network. It's designed to bring us all together to discuss and share knowledge regarding one common topic. And today's call is going to be very interactive, where you'll see two polling questions, and again, you'll have the ability to submit comments to us via chat. Now, prior to today's call, we actually sent out pre-work, giving you the ability to share your thoughts as it relates to the topic that's going to be covered before we officially got started, to give us a chance to know, once again, who will be on and just your understanding and knowledge of the topic that will be covered. Now, there are four questions. The first one asks, does your facility have a transitional care unit on site? For this question, it shows that 441 folks replied, and of those who replied, 9.98% or 44 of those individuals said yes, but the majority, 397 or over 90%, indicated no to this question. Question number two asks, does your facility provide patient education on home modality as a treatment option? Of those who replied, 442, so 437 indicated yes, with about 1.13% saying no to this question. And then the third question indicated if you selected yes to the previous, does your facility work with nephrologists to help patients get on a home modality treatment plan? And of those who replied, 442 folks total, 428 said yes to this question, and 14 indicated no. Now, question four was an open-ended or free text question. Here you can see just a word cloud that was generated automatically by the webinar or the tool that we use. So some of the words, they're just displayed on screen, but the responses that we received, actually 436 people in all replied, and we saw a lot of the feedback that we received indicated education and demonstration. We saw patients are referred to the home nurse for follow-up, refer to home patient coordinator, arrange education with home therapy nurses. So a lot of great feedback was received as it relates to the fourth question. Unfortunately, we don't have the ability to show 436 replies on screen, but we just have just a screenshot of word cloud that was generated based on some of the answers that were received. A couple of things just wanted to provide you with our Learning and Action Network calls. We provide questions to run on, things that we want for you to think about, not just today after you hear the presentation, but in the upcoming days and weeks. With the first question is, what one idea to increase patients dialyzing at home are you excited to try at your facility? What steps will you take to implement a new idea to help patients move their dialysis to home in your patient population, as well as what actions have you and your facility taken to help patients dialyze at home, and how can you share that to help other patients. At the end of the call, actually, we'd like to ask, based on the presentation, what is something that you heard that you're excited to try at your facility? So just listen, even though we'll be sharing the call will be focusing on one particular topic, a lot of things will be said that you can, I like that. I could potentially apply that at my unit, and we want to hear from you in how you plan to use that. All right, just a couple things as it relates to housekeeping. The screenshot might be small, but I wanted to mention the fact that we are providing one continuing education, giving you the ability to get one continuing education unit. At the end of the call, a post-event evaluation will display. We'll work on making the image a little bit bigger next time, but a post-event evaluation will display, giving you the ability to share your thoughts. Once you're done, a screen that looks kind of like the screenshot that you see here will display, giving you the ability to access the system that contains the certificate so that you can print out access for today's call. Okay, thank you. So for today's presentation, you're going to hear from two folks. The first individual you're going to hear from in a moment is Dr. Robert Lockridge. He is a retired clinical nephrologist and member of the Lynchburg Nephrology Physicians. He was medical director of the home dialysis program at Lynchburg Dialysis Facility. He grew the peritoneal program from no patients in 1982 to 60 peritoneal dialysis patients in 1996. Dr. Lockridge started the first nocturnal home dialysis program in the United States in September 1997. Also, you're going to hear a little bit later from Lisa Hart. She is the optimal transition manager at Satellite Healthcare in Sacramento, California. She has been heavily involved in design, development, implementing, and managing the management of the optimal transitions program, delivering intensive education on all modalities. With that, it brings me great pleasure to turn the call over to Dr. Lockridge. Thank you.
First of all, I'd like to thank the National Home Dialysis Learning and Action Network for inviting me to be a part of the program. And I think this gives me a great opportunity to share some ideas that I think can make a difference in outcome. Next slide. My goal today is to understand what happens to our dialysis patients in the first year of in-center dialysis, for you to understand, and then talk a little bit about the concept of the transitional care unit, and then really focus on the why, who, where, how of implementing of transitional care unit, and then to answer questions. Next slide. So what happens to a dialysis patient in the first year of in-center dialysis? Next slide. It's important to know that over 50% of patients crash into dialysis. That means that people have been not seen by a nephrologist or have not been seen by a nephrologist for greater than 12 months, who show up in the emergency room and crash because of an acute illness on top of a chronic illness and require the initiation of dialysis. So it's really important to understand who these people are and how they feel. Next slide. So it's important to understand that patients are frightened because they are overwhelmed with anxiety and fear of dialysis. So I'm retired now. I deliver Meals on Wheels every other Wednesday. And the first gentleman on my circuit of delivering meals is my age, 70. He has chronic kidney disease and is followed by my old practice. And I asked him one day how his kidney disease was doing, and he, of course, said, well, you know that sign in the office? I'm CKD3. I understand all about dialysis, and my kidney function is stable. Then I asked him the question, has anybody talked to you about dialysis? And he raised up both hands and said, I don't want to have anything to do with dialysis. In my community, my church, it means you're going to die. So why sign up for something that's going to kill you. And that was his perception, and I think the perception of a lot of people that we start on dialysis today. People on dialysis that start typically are fluid overloaded, and they have decreased mental capacity, and they have really a poor health understanding of disease state. What they need is a time to adjust mentally when they start dialysis. They need a therapy to address their medical needs, whether it be fluid, potassium, acid base, etc. And they need modality education so that each patient that starts dialysis has the ability to have an informed choice. Next slide. So the first a poll question for you to answer, and this really kind of tells us a little bit about what's happening in the United States. What percentage of patients initiating in-center hemodialysis in the United States in 2015 had a working AV fistula? Less than 20%, 20 to 30, 30 to 50, 50 to 70, or greater than 70. I look forward to your answers.
All right, everyone, thank you so much. So actually on screen you should see the poll displayed. We had the slide that had the question so that you would see it beforehand, but now on screen you should see the question that was asked a moment ago, giving you the ability to provide a response. All right. All right, it does show that we've received feedback, or we're getting feedback from folks. We do have about 776 webinar connections, and I'm sure there are also folks who are currently connected just to the telephone or audio as well. So thank you all so much for joining us. Okay. Giving you a chance to provide your thoughts, and then we'll close the polling out in a moment. Just please make your selection, click the submit button. Again, the question is, what percentage of patients initiating in-center hemodialysis in the United States in 2025 had a working AVF? Less than 20%, 20 to 30%, 30 to 50%, 50 to 70%, or greater than 70%. All right, I see that it's starting to slow down a little bit, so if it's all right with everyone, we'll do a quick countdown, giving you a chance to submit your thoughts, and then we can close the polling. So 3, 2, and a 1. All right, so here we go. So it does show of the 545 folks who provided a response to this question, over 49.5% of you indicated less than 20%, so that's 270 folks. 149 folks selected 20 to 30. 87 of those who replied said 30 to 50. 31 of those who replied said 50 to 70, and about 8 folks said greater than 70. With that, let me go ahead and turn over to you, Dr. Lockridge, to assist with the results of the answer.
So it's very important to understand this. This really explains that in 2003, we in the United States, because there was very few people starting with dialysis with fistulas or being maintained on dialysis with fistulas, about 33% prevalent patients. But what this shows, even with the effort of Fistula First, even with the education, that fundamentally from 2005 to 2015, the number of people that have a fistula are less than 20% starting dialysis. So it's a real disconnect, because I know we've made a tremendous effort to try to have people have fistulas when they start dialysis. So I think it reflects what that man told me when he held up both hands. And his idea is that you're going to die when you start dialysis. So they're not going to do, patients are not going to select or do a fistula or make other decisions until they actually have to. Next slide. It's also important to note that this period of time, the first 90 days of starting dialysis, is a critical period. Over the years, the last 20 years, we have improved mortality by 25%. We have had KDOKI created. We have had quality initiative programs created by CMS. We have bundle payments. But the bottom line is that in the first 90 days of dialysis, in the first year of dialysis, is the highest point of mortality, 3 times greater than what happens traditionally in prevalent patients. And the hospitalization rate is 2 times that of what's happening in the prevalent population. So we have high mortality and high hospitalizations. Both of those translate into a very miserable patient that has the possibility of dying and a very costly patient. Next slide. I'm sorry, I lost the slide. My computer went to sleep. So it's very important to understand that the major cause of death in the first year of dialysis in center in incident patients is cardiovascular. And it's as bad as cardiovascular-related deaths associated with sudden death, to cardiomyopathy, to stunning, to pressure overload and volume overload. But the key thing is that patients die because of cardiovascular issues. Next slide. In the first year. And this goes to the thing that we want to talk about, the cost. You can see Medicare cost goes up significantly, as well as private insurance goes up significantly in the transition of stage CKD 5 to CKD 5D. And it happens around the first month before it goes up, and then it goes up suddenly and down. So economically, there's a real reason to focus on this area also. Next slide. So the next polling question, and I think it's very important for us to understand about education, and the real question that we're talking about is, does education of the patient about renal replacement therapy options work? Back in when the conditions of coverage changed in 2008, after 30 years, there was a lot of studies that showed that nobody was being educated about transplant PD and particularly about home hemodialysis. So the major providers developed training programs to basically educate people about the modality options they have. Next slide. So what I want you to do is answer this question. What percentage of DaVita patients or FMC patients, which make up over 2/3 of people initiating dialysis today, 124,000 people initiating dialysis, in 2016 had received Kidney Smart, which is the DaVita education program, or TOPS, which in 2016 was their education? Less than 20, 20 to 30, 30 to 50, 50 to 70, or greater than 70.
All right, thank you so much. So you should see about the polling on screen now. We do understand that we have a lot of different folks affiliated with a lot of or various facilities on, so some might not be able to answer this question, but you can go ahead and share your thoughts. Again, with these polling, we're not grading them. We're not, we're just giving you a chance to add your voice to the overall conversation. So I do see that we're getting pretty good feedback, response from folks. Where again, the question is, what percentage of DaVita and FMC or FKC patients initiating in-center hemodialysis in 2016 had received Kidney Smart or TOPS education prior to starting dialysis, with the same answer options: less than 20, 20 to 30, 30 to 50, 50 to 70, or greater than 70%. So, all right, so I'll give you a chance again to just share your thoughts, make a selection, and then we'll close the polling out. I see that we receive feedback from more than last time, so it's very good. So let's go ahead and do the quick countdown if that's all right with everyone, so that we can share the results with all. And turn it back over to Dr. Lockridge to assist us with the presentation today. So it's starting to slow down a little bit. So 3, make your selection, click the submit button. 2, and 1. All right, here we go. So of the 574 folks who provided a response to this question, it shows that 202 indicated less than 20, 190 said 20 to 30. Oh, okay, the results displayed to the right as well. So 124 indicated 30 to 50, 41 who replied said 50 to 70, and greater than 70 was selected by 17 of those who replied. So let me go ahead and bring up the next slide for you, Dr. Lockridge, and I'll turn over to you to assist us with the answer to this question.
So I think it's very important to understand that, like I said, all providers are required by the conditions of coverage to educate people in modality options. And the bottom line is that DaVita Kidney Smart, which I've gone through classes twice, takes about 90 minutes, only were given to 25 to 30% of the people, and TOPS were only given to 25 to 30% of the people. And it's important to note, if patients chose that, which is selection, they went and heard that there was 4 times more likely to choose home dialysis. The real thing is that if you really look at it, if 50% are crashing into dialysis, that means that this is only 25 to 30% of people that actually have the opportunity to be exposed to education out of the 50%. And it's also important to note that in reality, both companies realize that this is a problem and are changing the modality of education it can. And it's a true fact because when these folks do the test, the Social Security number goes in the DaVita or Fresenius computer system, and when they start in center, their Social Security goes in and one button tells all. So this is real facts about education. We're not educating our people about ESRD modality options. We're trying, but it's very difficult, and it's partly related, I think, more related to what the patient wants than anything else. Next slide. So the concept of a transitional care unit. This is not something new. It's something that's been around a long time. And what I want to share with you quickly is what has happened in the past and where I think we should go in the future. Next slide. So this is actually a table and an article that was written, published in March of 2018 in AJKD about the improving instant ESRD care via a transitional care unit. If you look, the first paper goes back to Northwest Kidney Center, and this was in 1981. Chris Bragg realized that the number of people choosing home therapies had fallen from 70% to 50%, which is unbelievable. And he created a 6-station orientation unit for 2 months of education and was able to bring home dialysis back up to 70 or 80% choosing home therapy just by orientating educational program built within the in-center unit right next door to the home training unit. The other studies I'm not going to go into, but used particularly a nurse navigator or a nurse manager for all people starting dialysis, and they showed a significant reduction in mortality, hospitalization, and a patient better educated. So there was an increased selection of home modality, particularly more PD than home hemo based on the literature and what was being pushed. But education does work, and at this transition, it's very important. Next slide. So there was a group of people in the United States that got together in December of 2016, and these are the list of the names. And what we did was to got together to try to formulate a description of what a transitional care looks like, how it works, and how it goes. So the data that I'm going to share with you is really a composite of this group of people over a year time working on the description based on transitional units that were in existence at that time. Next slide. So what is the definition of a transitional care unit? First of all, the definition, next slide, is a patient-centered 4-week educational program for all appropriate patients starting dialysis. That's critical, all appropriate patients starting dialysis. It's important to note that once you're in center for 60 to 90 days, you tend to stay in center, and it's very difficult to move you out, no matter what you do. So it's important to address those people initiating dialysis. With this, we came up with you should use the home hemodialysis machine of choice. You should eliminate the 2-day killer gap. And all of us know what the 2-day killer gap is. It's a 2-day without dialysis. It occurs on Monday, Wednesday, and Friday on Monday, and on Tuesday, Thursday, Saturday on Tuesday. And in 1999 and again in 2011, the data showed there's a 45% increase in mortality on those days depending on your schedule. We should eliminate the fear and preconceived ideas. I was in North Carolina talking, and a social worker came up to me afterwards and said, did you know, I've had a kidney transplant, but I was on dialysis for a year and a half, and I feared every day I went to dialysis. And do we know that about our patients? And do we understand what lifestyle patients want and medical goals that patient has? It varies between the age of the person. Say a 45-year-old that has 2 kids and his family, and he never had the opportunity to finish high school, and he wants to see his kids graduate from high school because they are working toward this, and he anticipates them. If he has end-stage renal disease with diabetes at age 45, the chance is he won't see those kids graduate from high school because he won't be here. So we need to understand the medical goals. Somebody that's retired has a different goal. Somebody that's 75 has a different goal. And then we need to educate people about renal replacement on all modalities to include in-center, PD-HHD. And then we need to have an access plan. The most recent ESRD data shows that people starting in the United States on dialysis today, 80%, even with fistula first, still would start with a catheter. And at 3 months, they still 70% have a catheter. And it's important to note that everybody, if you walked into a unit and saw machines and saw dialysis, nurses and everybody running around, your first question is, who's going to pay for it? Next slide. So why should we have a transitional unit? It's clear. In the first 90 days, everybody is at high risk initiating dialysis. 3 times greater death rate, 2 times greater hospitalization, high anxiety, and access problems. Next slide. And we should be starting all new patients in this transitional unit and failed PD, failed HHD, and failed transplant because they are at the highest risk, failed transplant, failed HHD, and failed PD. It's important to note you have to, next slide. So which patients should you not put in a transitional unit? So if somebody goes through the educational system, whatever it be, in the physician's office, in the dialysis facility, and they choose a home modality, they should go not to the transitional unit, but directly to the home training unit because they will be educated about everything that's going to happen in the transitional unit. A patient that is a permanent resident of a long-term care facility certainly should have education, but not the intense transitional care unit education because then you're going to give them false hope that they should do something else or want to do something else and they can't do because of the facility. Patients that in hospice care at the physician's recommendation, patient that has significant cognitive dysfunction. Now, I've had a lady that was 75 that was mentally not very capable. I trained 3 of her daughters to do home dialysis because they wanted her at home. Patients that are not in a stable living condition. So those are the criteria that would keep people from doing the transitional unit. It only makes up 10 to 15% of the population that we care for. Next slide. Okay, where should a transitional care unit be? First of all, you have to do your homework. So in Lynchburg, Virginia, we have a 43-station unit. We have 4 satellites within a 20-mile radius of that big unit, and we manage about 350 ESRD patients that are on dialysis. So we figure that we start 6 to 9 new patients a month. So the size of the transitional unit is based on who's going to be coming. The unit can be an in-center station, it can be a home training station, can be freestanding, or it should be designed in every new unit that we have. So the location is important, but most importantly, you need to figure out if you build it, who's going to come and how many, and if you do all initiating dialysis, that's the number you build your unit to. Next slide. So it should be in-center station, home hemo first, but the key thing is before you choose where it's going to be, you look at the space you have and you look at CMS rules in your region and your state rules in their region before you choose. Next slide. Next, about dialysis prescription. It's very important, and we thought a lot about this. You want to provide an optimal general dialysis with the home hemodialysis machine of choice. The three biggest reasons people don't choose home hemodialysis: number one, sticking; number two, the fear of the machine; and number three, a catastrophe of occurring on the machine. So dialyzing for a month on the home machine gives the patient the comfort to make that decision. You certainly would share with them the cycle of peritoneal dialysis, the peritoneal tube on the dummy, the needle access dummy. You would share that, but to experience the home training machine is critical for helping them feel comfortable to make that choice. You should do 4 to 5 treatments per week, eliminating the 2-day killer gap. You should use a blood dialysis flow rate similar, consistent with your home dialysis prescription, and you should never do more than 10 to 13 liters per kilo per hour removal of fluid, and no less than 12 hours. Now, those three things, the last things, the blood flow and the length of time and ultrafiltration, fundamentally preserve residual renal function. So you have people starting that have a residual renal function. You don't want to dry them out. You don't want to crash them. So that's why you extend the frequency. That's why you limit the ultrafiltration and extend the hours when you do in the transitional unit. It's gentler, slower, they feel better, and they preserve residual renal function. And then you use the standard EPO iron weight laboratory protocols Excel that's in center. Next slide. So 4-week educational program for the transitional care unit. What is it? Next slide. It's pretty practical. The first week you deal with the emotions, you eliminate the fears, you explain the cause of the renal disease. 50% don't know, and you explain the cause. The second week you do a general overview, review quality of life for each modality, review clinical outcomes for each modality. But the most important thing is you have a user tool that tells you what the patient wants. It's called My Life, My Dialysis Choice. It's on the Medical Educational Institute. Go to the website, take the test. There are 24 things that matter, some about medical matters, some about life value matters, and some about caregivers matters. Select 3 of those and help the patient go through this web-based questionnaire, and it gives them an idea or a scoring of what modality would best suit their needs for what they want. It's very important because it can be printed out, put on the chart so the social worker, the dietitian, the physician, and the nurse and the family all understand what the patient wants. Next slide. The third week is an intense education on transplant and access, peritoneal dialysis, and center education. You do all the education. But the most important thing is you have the patient exposed to a patient on PD, exposed to an HHD patient, a transplant patient, and an in-center patient. For at least 30 minutes during that setting, you arrange for somebody to come and talk to them. They believe what we say, but they will look at somebody doing it and have a much more comfort or ease. And the final week, you review the renal replacement therapy and access. You refer to transplant if they chose transplant. You refer to home or in-center what they chose. And they leave the program after 1 month with an access in plan, scheduled for surgery or whatever, based on their modality selection. Next slide. So finally, we'll look at staffing. I think the staffing model can be an in-center model, a little bit different by the fact you'd have 1 RN to 2 to 3 PCTs. The PCTs would do the dialysis. teach them, set up the home training machine. The nurse would do the education. An RN administrator, the ratio of dietitians, social workers, PCCU should be similar to in-center. The most important thing is that the medical director for the home training unit and the TCU need to talk. If you take all of a sudden and go from 10% choosing home therapy to 30% choosing home therapy, you've got to deal with the influx. So you need to plan ahead how you're going to deal with that. Next slide. So this is an exciting time for the renal community. We as a community, we have tried to educate physicians, and I think physicians would choose home therapy for themselves, but it's very difficult when they are not trained to do home therapy. So we as a renal community need to educate the patient, let the patient be better educated, make the choice, and then evolve how we take care of them at home. Next slide. There's my email, my cell phone number, and certainly if you email me or text me, I'll be glad to help you in whatever way I can to advance this concept of transitional care unit. Questions?
All right, Dr. Lockridge, thank you so much for your presentation today. What we want to do actually, instead of jumping into the questions right now, we'll give Lisa Hart a chance to present her slides as well, and also give folks a chance to think about the questions based on what you've covered, as well as what Lisa will cover in a moment. So we can just tackle those at that time. And just a reminder, folks, if you have questions, please, you can indicate who the question is for. You can say for Dr. Lockridge or Lisa, and then submit your question. So what we'll do at this time, I'll go ahead and turn over to Lisa Hart to assist us with her presentation, and then we'll circle back for the question. So Lisa, I will turn it to you at this time. Thank you.
Thank you. So thank you for inviting me to speak today, and good afternoon to everyone listening. I am the nurse manager of the Satellite Dialysis Optimal Transitions program. I do need to say that Optimal Transitions is a trademarked program of Satellite Dialysis, so I won't be speaking specifically about the specifics of our program, our statistics, but rather generically about what are the things that you need to think about in terms of starting a program like this. Next slide, please. So number one, Dr. Lockridge touched on this. Choosing your location is a pretty essential piece of this. You want to think about where do we want this to take place. Ideally, it should be in center, although home facilities might be a good choice if space allows. What we really looked at when we decided where to place ours was what was our potential audience. So in center is kind of an ideal location in terms of visibility for existing patients and easy access for patients to come into the program, and if they should choose to go in center, giving their familiarity with the staff. Ideally in a separate area or semi-separate area within the clinic for noise control, and so that you can actually do the education that you're hoping to do. But again, it is pretty optimal to have other patients seeing what's going on and becoming curious about what we're doing. And like I said, it can be done in a home dialysis training center or an independent center if there's space available. Next slide. Staff selection, I think, is probably the second most important piece of starting a program like this. I think these type of programs are primarily staff-driven with the support, obviously, of the medical director, referring physicians, and coordination of other programs and staff members into the program. But essentially, you need at least one dedicated RN that is going to be dedicated exclusively to this program. It's optimal to have that nurse have experience in all modalities and having a really strong desire to educate patients and provide the support that's needed. Dr. Lockridge talked about what patients are coming to us like and experiencing. They're often very anxious, very unsure of choices that lie ahead of them, and a lot of fear about needles and things like that. The nurse needs to be pretty independent, pretty self-directed, and ultimately non-biased. So it is ideal to have a nurse that strongly supports home therapies, but also is going to be able to listen to the patient and find out what their choices are. CCHTs involved in the program need to have excellent cannulation skills. They're going to be working pretty independently and not moving back and forth with the traditional unit staff. So they need to be strong in their practice and cannulation skills and pretty versatile in their people skills. We see lots of different types of patients just like we would in center, but we're spending a great deal more time with them. And so the CCHT has the most contact with them. It's very useful to carefully select that person to have an adaptable personality to the types of patients that we're seeing. And they also need to be interested in education and reinforcing what the RN is teaching. This is opinion, but in my opinion, the RN and the CCHT working together need to be really strongly bonded and able to communicate freely. Doing this type of program, you have pretty intense contact with patients. You have a lot of change and adaptation that needs to be made along the way. And so those 2 people or 3 people, depending on your circumstances, need to be people that work together well, can communicate freely, and plan differences and changes in strategy as they go along. Next slide. Program design. So Dr. Lockridge talked a lot about the types of things that could be done in a program. It's up to each location to decide what they want to include. Before you get started, you want to spend a lot of thoughtful time and consideration on what is the goal of the program, what things do you want to include, and what is your timeline. Traditionally, about 4 weeks does seem to work very well. And then you need to think about, are we going to, during that 4 weeks, after we stabilize people and get them comfortable, do we want to do self-care? Are we going to teach them to cannulate? Are we going to have them do their own vital signs, set up their machine, and start learning those things in the event that they do progress to home hemo? We have found it fairly helpful to allow that to happen. And again, what's your timeline of how much time do you want to allow for stabilization, getting used to the environment, and exploring with the patient what they do want to do? We tend to spend a good week and a half doing those things, getting them through the admission process and really just kind of talking, filling out some questionnaires and finding out what their lifestyle is, what their interests are, what they want to do, and how they spend their free time, because that often influences the choice that they'll make. Next slide. So organization and implementation, these are things that kind of need to be sketched out before you start. Sometimes you learn new things as you get started, and sometimes there's some hard lessons as you try things. But hours of operation need to be established early on so that you know what time periods you can train for people. Some people work, some people go to school, so you need to kind of figure out how much flexibility you're able to offer for them. Acceptance criteria. Dr. Lockridge did mention this, and this is kind of our way that we're looking at things in this program, is all patients with a possible interest in home therapy and have the reasonable ability to do a home therapy, we are taking into this program. So we do exclude people with severe mental illness, living in nursing homes on a permanent basis, or absolutely no interest in a home therapy. Other than that, the education benefits everyone, and we don't turn people away. You do need to think about your supplies and how you're going to order them and have them ready for patients. Unlike a traditional home training program, you don't know what patient is coming and when, so you need to have some things on stock and ready to go, and then as they enter the program, you can order supplies individual to the patient. Education materials, what handouts and materials do you want to use? They can be created by your company, they can be created by an individual and then approved by your company. We obviously have some handouts and some education books that belong to satellite dialysis that we incorporate in, and then we supplement it with other materials, but that needs to be thought out in advance. How you're going to promote your program, so you need to get the word out somehow to make sure that you are getting referrals, so brochures, flyers, doing lobby days, possibly meeting with physicians in the community. That's all going to be sort of individualized depending on what your circumstances are and where you're practicing, but you want to get the word out in advance of starting if you can, and then on a continuing basis. And last but not least, and probably one of the most important, is making sure that if you are in an in-center unit, that you educate the existing staff on that unit so they know what you're doing and they understand what you're doing, and they can explain it to in-center patients who ask questions and can kind of support the process of if an in-center patient moves over to the transitional unit, that they don't see that as a threat to their staffing and their patient population, and that we're all working towards the same goal. Next slide. Technical issues to think about. The area that you're going to practice in, you need to obviously have phone and computer access. It's nice to have a dedicated nurses station. Forms and handouts, again, you want to make sure that you have those and have those ready to go. And then what kind of technology you're going to use. So we all know that there's some amazing educational resources out there these days that can be used. So think about whether you want to use video. If you want to use an iPad to use some programs that are available or things that you want to show patients, that can come in handy. There's CDs, DVDs, all kinds of tools that are out there. You just have to kind of think about what you're going to use and then the equipment related to that. Charting. Most of us come from a world now where we have EMRs that connect to our dialysis machines, and that is not yet the case with most EMR systems and the next stage equipment, which often you'll be using. So you do need to think out, how are we going to accomplish the goal of the charting and then getting that to our EMR. So in many cases, you're going to be doing some manual charting until and when that is figured out, or it may be on a permanent basis that you're dealing with manual charting and then how to get that to the EMR. And last but not least, billing. If your transitional unit is in-center, then you're going to be billing that treatment as an in-center treatment. If you have a transitional program that includes training, then you need to think about the transition between the transitional period and the training so that billing differentiation can take place. Next slide. So here, essentially, in a generic way, I'm going to share with you what our success has been. Again, it is a trademark program, so I've been asked not to talk about specifics, but I think this program has, in the year and a half that we've been functioning, been a win-win for everyone involved. We are seeing more than 50% of our patients choose a home modality. We have had no dropout of patients due to treatment burden or issues related to treatment. We are feeling that the education that they receive during the transitional period plays directly into training and has helped them be even more successful than some patients who go direct to training. Also, if they choose not to select PD or HHD, the seed has been planted. And we have found that some of the patients who have chosen to go in-center are still asking questions, still making plans for possibly doing it in the future, or still showing interest. So that may be a payoff we haven't seen yet. And then as an educator, this is one of the things that I think isn't real visual yet in doing a transitional unit, but of the patients who have not chosen home, most of the patients that we have had go through our program that are in-center are requesting or demanding 4 treatments a week. They run their full treatments. They advocate for themselves, and they are much more adherent to the dialysis prescription medications, the fluid and dietary restrictions, that we use in the dialysis world, and all in all, that makes a better, healthier patient. So I think regardless of the patient's choice at the end of the transition, we have benefited patients through the education, and so I consider that a success regardless of what they choose. Next, actually, I think that's the last slide. So,
Thank
Neil,
you.
you're welcome.
Go ahead.
Oh, I was going to say the patient who's going to speak is here with me and ready when you are.
Yep, we're ready right now. Go ahead. Thank you.
Hi, my name is Chelsea. I am a patient. I currently do the home hemodialysis, and I came into the program actually with my doctor, who recommended that I do home hemodialysis. She was an advocate for it, and she kept asking me if I wanted to do it, and I said I might be interested. I had an AV fistula put in 2012, so I had it for a while. And so when it was time to start dialysis in September 2017, she recommended satellite dialysis for me. And during, it was a rough start, to say the least, but it was one of the best things that I could have done. I knew that in-center was not going to be an option for me. I knew I did not want to do that, and I wanted to have more control over my health and be a self-advocate. And so to this day, I still do it at home. I do it 4 days a week, and I would not choose any other way to do dialysis. I feel better, and like I said, I would never do it any other way. And I feel very lucky to have this program available to me, because I know a lot of people don't have these kind of programs available to them, and it really makes a difference. And the training was, I was scared at first. I was told that I never wanted to do dialysis. It was going to be a horrible thing, and this changed my idea of it. I actually don't mind doing it, and I feel a lot better because of it.
Well, Chelsea, thank you so much for sharing your testimonial with us. We truly appreciate it. Anytime we're able to get a patient on to just kind of connect the pieces, just how, based on the topic that's being discussed, and how is it being used or applied at all levels. So thank you so much for sharing with us. Now, we do have about 7 minutes remaining on today's call. We received a lot of great questions. I will say we might not have time to get to all the questions today. But we are capturing the questions, just so you know. But let's go ahead and we'll ask in the order in which they were submitted. The first question that came in a little bit earlier for Dr. Lockridge. This was submitted by Judith. What is holding up patients being referred to a nephrologist early instead of just falling into an emergency room in critical conditions?
So first of all, I think that a lot of patients are not referred or seeing a nephrologist. If you look at the data, the most recent data, about a third are seen by a nephrologist for greater than a year, a third for greater than 6 months, and then or 6 months or less, and then a third have no dialysis experience. So on the 2728, there is a form that you check off how long has the nephrologist followed you. So the data is out there, and in fact, people just are not seen. It's not that the nephrologists don't want to see them. It's not that they can't be cared for. It's that the patient is not seen, maybe because of insurance issues, maybe because of his primary care doctor, her primary care doctor. But clearly, a large percentage are not seen. And if they're seen, they're not followed for 12 months before starting dialysis.
All right, thank you so much, Dr. Lockridge. The next question is for me, the question regarding whether or not the slides and information will be made available. Yes, within 10 business days, we'll be sharing it with the ESRD network representative. Wanted to mention that to the group, and that today's call is recorded, and so you'll get that information within 10 business days from the network rep who invited you to join today's call. The next question, Dr. Lockridge, is that access? Go ahead.
I have three appendix on theirs that looks at a lot of data about how you can introduce this or look at it. So there's a lot of data on my PowerPoint that you can have in addition to the slides I shared.
Thank you for adding that. I totally forgot to mention, yes, that the version that is sent out will include the appendix as well, so thank you. The next question is that access tool, or I'm sorry, is that assessment tool absolute or suggestive? What I mean, have it been proven as an effective tool to use to help patients to select the best modality for their lifestyle?
It's been studied in 2 or 3 different places. One of the places that I think it most recently was studied that Fresenius tried it in their in-center unit and used the educational tool, and in fact it showed a significant uptake of people wanting to go or to hear about home dialysis. So I think that it has been tried in several places that's referenced in the tool, but the most recent was a Fresenius units that looked at it, looking at in-center patients.
All right. Thank you. And one more question for you, Dr. Lockridge, and then I see another that's for both you and for Lisa. So the next question for you is from Tim. Would you consider a former patient being involved with the transitional training?
Yeah, I think I mentioned that. I think that in week 3, we think that patients need to feel comfortable and understand their modality of choice. We think that a peritoneal dialysis patient, a home hemo patient, an in-center patient, or a transplant patient should sit down at bedside when the transitional patient is in the unit and talk to them about their therapy. We feel that that is critical in educating the patient. They understand what we as nurses or doctors say, but the best education is from the patient.
All right, thank you. With about 3 minutes remaining, I apologize once again. We did receive a lot of great questions that we're not going to be able to get a chance to get to today, but we are capturing these as well, and we'll provide additional information regarding the call, the questions received after the call as well. But the next question here is for Dr. Lockridge and Lisa. Thank you for the informative presentations. Do you think more resources need to be employed for these patients? Should we educate family? Should we have more intensive social work and dietitian involvement? Might we need more time, 6 to 8 weeks? Question mark.
Lisa, why don't
Dr.
you
Lockridge, did you want to take that first?
You can or I can. There are some people that talk about 6 to 8 weeks. Most of the units that are across the country that are doing it on average 4 weeks. Some take 3 weeks. Some take 5 weeks. I think that it doesn't. If you're training somebody in the transitional unit, and you're not going to cut them off at 4 weeks if they need 5 weeks. If they finish in 3 weeks, then you should be able to finish in 3 weeks. I think it's based on the patient's need, where he is. The patient may choose, say, I really like peritoneal dialysis. I've heard all this other stuff. I want to do PD dialysis. Then I would move them to home dialysis, placing a PD catheter early in the transitional unit. But I think this is about educating all people. And we're not having people educated. I think the literature clearly shows that. It's not that we don't want to. It's not that not all patients want to. I think we've got to have a system that will educate everybody, and not the in-centers that are there, but the people initiating dialysis. 124,000 people started dialysis last year. There's 100,000 that need to be educated.
And I would agree with that completely.
All right, perfect. Thank you. Well, folks, thank you so much for joining us for today's call. We're excited to see the over 800 folks who had joined us for today's discussion. Just wanted to provide a reminder regarding the fact that in the moment when we end the event, a post-event evaluation will display, giving you the ability to share your thoughts. And, thank you once again, Dr. Lockridge, and thank you, Lisa, as well as Chelsea, for sharing on today's call. So, everyone, thank you for joining us. And one more thing, just wanted to mention, if you don't currently follow in the ESRD NCC on Facebook, Twitter, YouTube, we do post information and things that are shared as part of our discussion, in addition to sending them to your ESRD network representative to share with you. So if you currently do not follow us, please do so. We would more than appreciate it. And thank you, everyone, once again. We hope that you have a great day, and we will see you on a future call. This will conclude today's call. Thank you, everyone.